Hello, my name is Susan Hester. I'm an RN CPN working at Children's Healthcare of Atlanta. I work in a pediatric technology-dependent ICU that specializes in respiratory distress. Today, I'm going to give an in-service on acute asthma exacerbation in the pediatric setting. I hope you enjoy it. So who does asthma affect? Well, asthma is the leading chronic disease affecting children in the United States. It's extremely common, affecting almost 8 million children, and is the leading cause for missed school days. Asthma is the third ranking cause of hospitalization for children under 15 years of age, the first being injury, the second being gastroenteritis. 50% of all asthma cases are pediatric. Here are just some statistics from the National Center for Health Statistics about the different age groups where children are diagnosed with asthma. You can see that there's a jump between 5 and 17 years of age, and this is believed to be exercise-induced asthma. Okay, so as we kind of move into asthma pathology, we're going to start looking at asthma triggers. We know that asthma is a hyperinflammatory response by the body after it has been exposed to an allergen. Some of those allergens are typically molds, animals, dust, also physical exercise, emotional stress, or viral bacterial infections. Even a change in the weather can trigger an asthma exacerbation. Individuals are genetically predisposed to react to these triggers, which explains the familial nature of this condition. An unfortunate side effect of repeated exposure to allergens means the body becomes more sensitized to the allergen and eventually requires a very small amount of the allergen to initiate an inflammatory response. Let's look at assessment findings for the asthmatic: dyspnea, tachypnea, of course wheezing, retracting nasal flaring, and the more ominous signs of head bobbing and grunting. Okay, so moving further along in pathophysiology, this is a rather simplistic diagram that kind of explains what's going on when we have an inflammatory response for asthma. You have a trigger, and that leads to airway inflammation, and that's when your histamine starts to really kick into high gear. That causes mucus production, and then bronchospasm, and then edema. So kind of that's the holy trinity of asthma. All three of these result in narrow breathing passages, which results in what we see assessment-wise: wheezing, cough, and shortness of breath. So sometimes it's helpful just to look at instead of just seeing a diagram, to actually look at some pictures of what's going on with the bronchioles with this pathology. So with the hypersecretion of histamine, you can see that you have increased mucus production. On the right, you see the affected bronchiole is full of yellow mucus. Also, you're having bronchospasm, that's the clenching, and the edema. And all three of these things result in airway constriction. So what's the significant difference between pediatric asthma exacerbations and adult? Well, as you can see, this diagram shows us what the trachea looks like, and an infant or a small child that is having an asthma exacerbation with bronchospasm as well as edema, their airways are just so small, 4 millimeters, that when they have the edema, they go down to 1 millimeter of patency, and that is dramatically different than an adult, and it can certainly be life-threatening. So let's look at some of the other pediatric differences. As we just looked at infants or children smaller than 3 years of age have very small pulmonary airways. They have poor collateral ventilation. Their diaphragm is not fully developed, so they really don't have forceful expiratory pressure, and they also might just present with a cough, and that is especially true when you hear a cough at night. That is kind of the hallmark of chronic asthma. So let's now look at some of the treatment modalities for pediatric asthma. Oxygen for anyone in a hypoxic state, whether it be by nasal cannula, Veni mask, or perhaps a non-rebreather for severe hypoxia. Inhaled beta-2 agonists like albuterol and Xopenex are very common. These treatments are usually nebulized for 20 minutes times 3. However, it's very common to see continuous nebs over 1 hour. We're also seeing research now that is saying that metered dose inhalers, MDIs, are just as effective as nebulized treatments, so they are becoming very popular also in the emergency room. All right, other traditional treatment modalities that we see that we often use in the emergency room are anticholinergic medications like Atrovent. If you remember, anticholinergics are antispasmodics. They block the transmission of parasympathetic nerve impulses and relax smooth muscle, so that's going to handle our bronchospasm. Also, corticosteroids like Orapred or Solumedrol will decrease inflammation. So now we're going to look at some of the less traditional but more advanced modalities for asthma exacerbation treatment. And the first thing we're going to look at is magnesium sulfate. So what is the exact role of magnesium sulfate in acute, moderate to severe asthma? We know that magnesium sulfate is an important cofactor in over 300 enzymatic reactions in the body. It's a calcium channel blocker, and if you recall, calcium is important for muscle contractions. So if we want a bronchial dilator, this is a good choice for us. It also reduces histamine-induced bronchospasm. With magnesium sulfate administration, it's important for nursing to be aware that it has a 6-hour half-life. And so 6 hours after initial administration, you may have a rebound effect and a return for bronchial constriction. This slide shows a little case study that Hiram Habar, the pulmonologist in my unit, has put together for magnesium sulfate administration to moderate to severe asthmatics. As you can see, the FEV, or forced expiratory ventilation, is greatly increased over time with magnesium sulfate administration. Our hospital has in fact had such success with magnesium sulfate administration that we are now having all moderate to severe asthmatics receive this drug in the emergency room. These patients are no longer admitted to the ICU, but actually will go to the floor as long as they are monitored closely. The second advanced modality that we're going to look at is Heliox administration. Heliox is a blend of helium and oxygen to a ratio of 80 to 20%. It allows for easier flow into tight airway passages and less turbulence. It also diffuses carbon dioxide through the body much more quickly, and it can be very effective in delivering nebulized medications to distal airways in severe asthma exacerbations. Unlike magnesium sulfate, Heliox is almost always used in an ICU setting. Not so much because of the drug, but if your pediatric airway is so compromised that you're requiring Heliox, then the potential for intubation is quite high. The last of the treatment modalities that we're going to look at is ketamine administration. This is a very old drug, but it's got a new use here. It's a direct bronchial dilator, so it reduces bronchospasm, as well as promoting bronchorrhea, which is increased pulmonary secretions. And this certainly helps with any mucus plugging that might result from mucus secretion. Intubation should be considered a last resort for asthmatics. Your most experienced RN or a pediatric anesthesiologist should be doing this procedure because usually due to the bronchoconstriction you just get one shot. Finally, the children who are dying from asthma, 50% of deaths occur prior to the hospitalization. There are 4,000 pediatric deaths a year. It's a very serious disease. Many times this is due to improper prescription of medications or compliance with medications such as controller meds versus B agonists like albuterol. This brings us to the end of this in-service. I hope you guys enjoyed it. If you have any questions, please feel free to email me or discuss it at the WMVA session coming up. Thanks very much.